My name is Josh Rozell from NYU Langone Orthopedics, and this will be a surgical technique video of a Mako Unicompartmental knee arthroplasty. The patient's positioned supine on the table with a paint roller bump and a bump for the side of the greater trochanter. The foot is hung by the toes, and a down sheet is placed. Dura-prep is used to prep the skin to allow for increased stickiness of the I-band over the skin. Another down sheet is placed superiorly to cover the patient's head, followed by a sticky blue U-drape under the patient's thigh. Next, an impervious U-drape is again applied under the patient's proximal thigh, and the tails of the drape are crossed over to seal the barrier at the proximal edge of the skin. A bar drape is then placed proximally. The leg is taken down with a coker and a towel, and a stockinette is applied by grabbing the metatarsal heads and applying the stockinette over the toes and heel, such that the stockinette doesn't actually touch the toes. The stockinette is then rolled all the way up to the proximal thigh, and the foot, ankle, and lower leg are wrapped with Coban. The Coban includes the toes and is wrapped such that it's not too tight around the patient's leg. The Coban is bunched up so you're able to find the end once the procedure is over and you remove the Coban and stockinette. An extremity drape is then applied over the patient's leg, and this drape is given to anesthesia proximally. The stockinette is cut transversely on both sides without touching the skin. The proximal edge and distal edge of the stockinette is rolled and grabbed by the assistant, and 4 hash marks are placed along the knee to allow for cosmetic closure at the end of the case. This marking pen is then discarded. An I-band is then placed over the skin in its entirety, with care not to cause any air bubbles around the site of the incision. The leg is then elevated. The drapes are pulled proximally, and the edges of the I-band are wrapped underneath the patient's leg to maximize coverage of the drapes with the I-band. There are also 2 I-band strips that are used to reinforce under the thigh and above the thigh. The leg is then flexed, and that second strip of I-band is applied over the proximal stockinette and drape. Outer gloves are changed. I always apply 3 gloves at the beginning of the case to increase efficiency. 2 non-penetrating clamps are placed so the drapes don't bunch up during the case. Light handles are applied, and the pulse lavage, bovie, and suction are attached. The pulse lavage is always given off first, as it takes the circulator the longest to connect it and prime it. All 3 attachments are then wrapped into the extremity drape, and the pouch is placed such that the top of the sticky part of the pouch is at the white attachment on the extremity drape. That just allows for the instruments to rest comfortably in there without falling out. The pulse lavage is clipped to the drape and primed, and the suction is turned off until it is needed. The incision is then marked with the leg in extension. First, I assess the deformity and the range of motion. I palpate the tibial tubercle and roll the pad of my thumb over medially. That's my first dot, and then I mark the supermedial edge of the patella. I then place my finger along the medial edge of the patella and connect the 2 dots such that the incision is slightly curved around the medial side of the knee. The incision is made just through the skin. No retractors are used at this portion of the case. We just use the natural tension of the skin for those fibers to open. I'm looking at the VMO, and I'm getting through those retinacular fibers to expose the arthrotomy site. Using just manual force, I'll retract some of those soft tissues and pull the retinacular tissue apart and get adequate hemostasis before proceeding. A blue marking pen is used to mark the supermedial edge of the patella into the vastus medialis to allow for closure at the end, and 30 cc's of 1% lidocaine with epinephrine are used to allow for better hemostasis because I don't use the tourniquet. The arthrotomy is made by using the flat belly of the knife in the straightest line possible without much curve up into the quadriceps tendon The arthrotomy is completed distally, popping through the anterior horn of the medial meniscus. The leg is then extended, the patella is subluxated laterally, and sharp dissection is performed by creating a triangular flap of tissue for later closure. This flap of tissue goes all the way back to the center in a triangular fashion. The knee is then flexed, the patella subluxated, and the lateral compartment of the knee is visualized to ensure that there's no arthritis. Here you can see some grade 1 changes behind the patella, which is of no significance. A Gelpi is inserted with one of the tines into the medial meniscus body and the other into the fat pad. The medial tissue on the femur is then exposed, and the Mako pins are inserted. I use the long guide and drill 2 pins into the femur. This is also used as a soft tissue retractor, so I'm rotating the guide as I put the second pin in to get good exposure for the rest of the case. As the femoral array is being applied, I've removed the lateral edge of the fat pad to improve my exposure of the medial femoral condyle and the medial tibial plateau. As you tighten the array, make sure you hold the pins to prevent any torquing and fracture. I then go about 1 handbreadth below the tibial tubercle. I make a small stab incision with an 11 blade, dilate it with a tonsil. I then take the short guide and mark where my second pin is going to be. Another small stab incision, dilation with the tonsil, and then insertion of the 2 pins bicortically along the medial face of the tibia. The incision is typically too small to put the pins intra-articularly, but if you choose to do so, typically the incision has to be lengthened a little bit. The tibial array is then applied and tightened, again holding the pins in place. The side post is then released to allow for external rotation of the hip as I rotate to get the hip center. The side post is then retightened, and the blunt probe is used to identify the medial malleoli, the lateral malleoli, and the arrays, as these are used for checkpoints. The Gelpi is then reinserted with the medial tine into the body of the meniscus and the lateral tine into the fat pad, and it rests on the array. The Z retractor is placed into the notch to adequately expose the femoral condyle, and here you can see the grade 4 changes of the arthritis. The sharp probe is then used to register the femur. I keep 2 hands on the probe at all times to maintain stability, and if there are any areas of cartilage, I'm always piercing the cartilage with the sharp tip of the probe, as the reference points are from the preoperative CT scan. I like to use the pedal on the Mako robot for this. I think it improves your efficiency. In order to access the points inside the lateral edge of the notch, the Z retractor is removed and the leg is slightly externally rotated so the angle of the probe is able to be seen by the camera. Once registered, a few of the bubbles are popped to confirm bony registration, and we move on to the tibial registration. The leg is slightly flexed to improve the exposure of the plateau, excess liquid is suctioned, and the tibia is registered in a similar fashion. It's important to note that the points don't have to exactly match the points on the software. As long as you're getting good registration in 3 planes, this should be sufficient for the robotic software. Again, I'm popping 2 or 3 bubbles, depending on the registration. And then once that's completed, you can then remove any overhanging osteophytes on the femoral side, as well as the tibial side if necessary. It's important not to remove these osteophytes until the registration is complete, as the CT scan is based on the bony anatomy of the patient. We'll then go into our poses. The leg is fully extended. The poses can be taken with either a device inserted into the intra-articular space in both extension and inflection. This can sometimes be difficult as the spoon might pop out. So sometimes I'll just do manual stress where I'll apply a valgus force for a medial uni and bring the leg throughout its range of motion as the Mako product specialist captures the poses. I'm also keeping in mind to keep the tibial rotation as constant as possible. Once the registration is complete, we see 2 bars of lines there. That's one from the registration with the spoons and one from the registration manually, and they look pretty much very similar. Bars above the 0 marking indicate looseness as a gap, and bars in orange below the line represent tightness. I like for the lines to be between 1 and 2 millimeters in flexion and extension, perhaps slightly looser in flexion. So this actually looks fairly good in terms of the balancing. Then I'm looking at the CT scan plan with the implants overlaid to make sure that the sizing is appropriate and to make sure that the tracking of the femoral component on the tibial component is adequate. I'm looking at the medial and lateral position as well as the slope of the implant, which I like to match the native bony anatomy. You want the implant to also mimic the shape of the medial femoral condyle, and you can see here the tracking is right in the center of that femoral component. So I don't think I really need to do much manipulation of the implants here, and we can go straight to the bone preparation. Again, I put the Gelpi into the medial meniscus. I register the tibial array as well as the Mako robotic arm. I insert the Z retractor into the notch, and then I bring my saw blade in. You can rotate the saw blade so it avoids bumping into the array, especially if you're not using checkpoints for these positions. The robotic arm is then brought in to cut the tibia. If the tibia is sclerotic, you can see I'm sort of hunting and pecking with the saw blade as it cleans the flutes with each pass. Haptic controls will guide you and will stop the blade if you go into an area outside that green landing zone. I'll then mark the femoral array checkpoint, and with the leg in slightly more flexion, I'll do the posterior femoral cut. It's important to optimize your efficiency and change the blade as infrequently as possible. So the tibia cut and the posterior femur cut are both done first with the saw blade, and then the burr attachment is used for the remaining portions of the resection. The saw blade has come off, and the burr attachment is attached and locked in, and the X is used to register. Here you can see I'm applying the fluid tubing to prevent any bone dust from flying out into the field during resection. The burr is then brought in, and the distal femoral surface is then burred. I try to go from superficial to deep so that the burr doesn't skip any lesions. And you can see the fluid coming out of that tubing during the resection to prevent any dry bone dust. Once that's completed, a central track is then burred through the femur. This is followed by the 2 femoral lug holes. One trick is to keep the burr perpendicular to the surface, otherwise sometimes the blade gets caught up. The area is suctioned of any debris, and then we'll move back to the tibia to do the resection with the burr along the medial spine. I'll start by doing the anterior 1/3 to 1/2 of the tibial surface. It's often difficult to get all the way into the back of the knee with the tibial bone still in place. So after I get most of the way there, I'll suction and use an osteotome to remove those bony fragments and then complete the resection. Here I'm using a 1/2 inch osteotome to remove that tibial surface. I also use it to remove the posterior femoral cut as well. I'll then go back with the burr to finish that posterior edge of the tibia, which is much easier now that that piece is removed. I'll then rotate the burr so it comes down vertically onto the tibial surface. again perpendicular to the surface, so that I can draw the 2 lug holes into the tibia. After this is complete, the Mako robot is moved out of the field, and we're then ready to prep our meniscus and trial our implants. I'll use a pituitary to kind of go around and clean up the remaining femoral resection surface, because there will be some cartilage flaps on the medial and lateral edges of the resection plane. Importantly, the femoral resection does not extend into the tide mark of the femur. You can see that anteriorly, and that is to prevent any patellofemoral impingement of the implant during range of motion. I'll remove the Gelpi and use a coker to grab onto the medial meniscus. This can often be a challenging part of the case because the area there is very small, so it's important to be patient and meticulous with your resection of the meniscus. Sometimes I'll apply a second coker to give some tension on the skin so that I can remove the meniscus in a more controlled fashion. The meniscus is very closely intertwined with the MCL, so it's important not to be too aggressive with your meniscus resection. Sometimes a valgus force on the knee can actually open up the medial space and allow you more space to take out the meniscus. The tibial trial is then impacted, followed by the femoral trial. I find it easier to use this inserter handle, and then I'll use a secondary impactor as well once this is twisted off. I'll then take my poly trial, and I always go one size below what the tibial size is. So if the tibia is prepped for a size 2, I'll use a size 1, and it just makes it easier to get the poly out after you're trialing. I'll then take the knee throughout a full range of motion, and then we'll repeat those poses from 0 to 120 degrees of flexion with a slight valgus force as we did in the beginning of the case. As you can see from the Mako balancing screen, the error bars are very close to neutral, which is very comforting in terms of the balancing and letting me know that there's good balance to the knee. So I'm happy with this. I'll remove the poly with the osteotome, and I'll remove the trial implants, the femur first, followed by the tibia, which is also removed with an osteotome. The knee is then irrigated copiously to remove any debris, while the rep opens the implants on the back table. At this time, I change my gloves as the implants are opened. The injection is prepared, which is Marcaine and Toradol. The bony surfaces are cleaned up, and again, in this particular situation, the patella is able to be subluxated laterally to allow full exposure of the medial femoral condyle and tibia. The injection is injected directly into the posterior medial capsule. This is followed by an injection into the medial periosteum, and you can see that tissue ballooning out. The periosteum and the synovial tissue are the most common areas of pain receptors in the knee. I also do it around the medial periosteum distally. While this is happening, the cement is being mixed on the back table. I use 1 bag of a medium viscosity cement. I think it allows for improved removal of the cement once the cement becomes doughy. There's a longer working time with medium viscosity cement compared to low viscosity cement. I then reinsert the Gelpi to improve my exposure. I dry the bony cut surfaces, including the lug holes of the femur and the tibia, and I'm now ready to cement the dry surfaces. If the patient has any intercondylar notch osteophytes, they can be removed at this time as well. Once the cement is in the doughy state, I apply a small amount to the underside of the implants, both the tibia and the femoral component. I do this with a 1/2 inch straight osteotome. I then apply a small amount of cement directly onto the osteotome, and I shape it so there's no free-hanging fragments. As my assistant again dries the tibial surface, I'm now ready to cement the implants. I press the cement posteriorly and drag the osteotome anteriorly to prevent any cement from leaking into the back of the knee. You really only need a very thin surface here, as you can see. I'm going to dry it again with a lap sponge. And then I insert the tibial component and use the impactor, first malleting posteriorly, so it moves all excess cement out the front of the knee instead of pushing it back into the joint. And then I'll mallet more centrally and axially until the component is appropriately seated. I then use a fine tip tonsil to remove any excess cement. And one key tip is applying a valgus force to open up that medial joint space to be able to access the posterior and posterior medial cement. I'll then dry the femoral bone and apply cement again to the lug holes. I'll use my thumb to put a thumbprint of cement on the posterior femur. Pressurize the lug holes, and then impact the femoral component using a secondary impactor. I'll remove excess cement again with the fine tip tonsil, again pulling the cement away from the joint as opposed to pushing it posteriorly. I'll apply some irrigation, get any excess cement out of the back of the knee, and then I'll put in the real polyethylene component and impact it into place. I'll then remove the Gelpi and bring the knee into extension. Remove any excess cement and place a bump under the knee so that the knee is appropriately tensioned in about 30 degrees of flexion, which is the optimal flexion to allow for the most force on the implant and pressurization. The arrays are then removed. Again, I've kept the femoral pins in place throughout the whole procedure to act as a soft tissue retractor. We'll irrigate the joint as the cement cures. I'll remove any excess cement after the secondary irrigation, just to clean up the joint. We'll also irrigate with a dilute chlorhexidine solution. In the case of unicompartmental knee arthroplasty, I avoid using betadine as it can be chondrotoxic. We'll again irrigate with normal saline, and then prepare for the closure. A new drape is applied underneath the knee to allow for a clean surface. Excess tissue along the medial edge of the arthrotomy, which includes the medial edge of the fat pad, is then removed to prevent impingement. 1 gram of vancomycin powder is applied to the joint, and we begin the closure with 1 rake and ovicral suture to reapproximate the arthrotomy. It's important to only grab the arthrotomy and not the synovium underneath. And here you can see that blue marking that I made at the beginning of the case is now well approximated for closure. I'll put 1 figure of 8 suture proximally and 1 distally as well before beginning the barbed suture closure of the arthrotomy. I like to hand tie these. I think it provides excellent soft tissue tension and minimal trauma to the tissues. Again, I'm grabbing just the arthrotomy and not the synovial tissue. I grab a small cuff of the patellar tendon and throw another figure of 8 suture in the distal arthrotomy. A barbed suture is then used to close the arthrotomy in a watertight fashion. Once the arthrotomy is closed, the wound is again irrigated, and another gram of vancomycin powder is applied to the superficial wound. 2-0 monocryl suture is then used for deep dermal closure, starting at the edge of the wound and progressing proximally to avoid leaving any holes in the closure. The last layer of closure is a 4-0 monocryl that is run in a subcuticular fashion to provide the final tissue sealant. The pin sites distally are closed with, again, 4-0 monocryl portal sutures. I find that using a portal suture rather than a deep dermal suture is better for wound closure, as the skin in this area is very thin. No tail is left, and these sutures will eventually fall out. The knee is dried, and a piece of silk fibrone adhesive is used over the incision, as well as the pin sites. And then an adhesive silver impregnated dressing is applied over this. This dressing stays on for 7 days and is then removed by the patient at home. The silk dressing will fall off after about 2 to 3 weeks.